Good evening, everyone. My name is Adam, and I'll be assisting Dr. Menbeu. First of all, I would like to say thank you for joining us at this evening. This is Blue Health Seminar. Blue Health Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. We are honored to have Dr. Menbeu here with us, updating us on updates on management of COVID-19. This session will last for 1 hour, and at the beginning, Dr. Menbeu will update us with his seminar. After that, we'll have a Q&A session, and at the end of the session, we'll be having a short quiz. To give you a background on Blue Health, Blue Health is a medical consulting company founded by medical doctors and a computer engineer. We do basic awareness on first aid or basic life support, and also advanced life support and other CPD trainings for health professionals. Since I already introduced myself in the company, Dr. Menbeu, you can take the stage and continue with your slide.
Okay. Good evening, everyone. Thank you very much for joining us in COVID case management update. This is almost a 40-minute presentation. Can you hear me?
Yes, we can hear you, Doctor.
Okay, thank you very much. So first of all, even if I am invited with the consultancy firm, I have no conflict of interest. I have no relation with any company for this presentation. I want to tell you that. So update in management of COVID-19, as you may guess, it will be a vast topic to present it, because COVID management by itself is a day's course. So we will just update and stimulate you to read the current managements and updates of COVID-19 illness. So the outline, it will be an introduction, some antimicrobials, whether they are working or not. And I will continue with what updates are there on outpatient management of COVID-19 and inpatient management, including severe and critically sick patient. And at last, we will see rehabilitation, which is forgotten part of management of COVID-19, where most patients after discharge will have some physical and mental disability. So regarding the update on introduction, as you know, more than 3.5 million people are affected with COVID, and now the Omicron is spreading worldwide fastly. The days with COVID-19 is more than 5.6 worldwide, and the total case in Ethiopia is around 462,000, and the total days in Ethiopia is around 7.2 thousand. And now Omicron variant is the dominant variant in the world. As you know, the WHO is nominating different kinds of the new when new variants are developing, the WHO is nominating it as with the alpha, beta, gamma, delta, something like that, but it is not following consequently. Omicron is the 15th word alphabetically, but some of the words were being skipped, like G, because it was a common name in China. So I think it is the 9th or 8th clinically significant variant, Omicron, but it is named in the 15th Latin word. And vaccination worldwide, 9.6 billion people are vaccinated in the world, which is more than the world population. As you know, this vaccination is being given in those countries where vaccine is being produced, in the Western nation. In Africa, as you know, it's not, the percentage of vaccination is very low. In Ethiopia, we have around 10 million vaccination, and we were using AstraZeneca vaccine. So the double dose are being given. So the percentage of vaccination is less than 4%, around 4% in Ethiopia. So the current variant Omicron, does it have a different sign and symptom? So the previous ones will have fever, cough, fatigue, anorexia, and some sore throat, less frequently headache, gastrointestinal symptom, and nasal congestion, and people were reporting loss of taste. Does the current Omicron variant have a different sign symptom was the question. And I think most of us are experienced the current flu in Ethiopia. Omicron, it has several mutations. So the question were whether it has a different sign symptom, and was it amenable for vaccine, and the other is were the treatments were working for Omicron variant also. So as it was the Omicron variant is affecting the younger population, mostly reported from South Africa. So more and more younger population are being affected by Omicron variant. Less symptom severity is being reported, like the sign and symptom is almost the same with the previous one, but the fever, cough, and loss of taste and smell are less frequently reported from Omicron. But flu-like symptoms like runny nose, headache, and severe fatigue, sneezing, and sore throat are being reported more frequently than the previous ones like Delta, but the mortality is less from the Omicron variant. Another difference from the initial case management of COVID is the WHO classification of illness in COVID. So previously, we were classifying COVID as mild, moderate, severe, and critical. So it has its own definition. Currently, they are classifying it as critical COVID, severe, and non-severe COVID. So critical COVID involves those conditions which require ICU admission, including ARDS, sepsis, septic shock, and this, if a patient develops this condition and requiring mechanical ventilation and vasopressor, we label him as critical COVID. Severe COVID are mainly those patients who require oxygen, who have oxygen saturation less than 90. By definition, those patients who require oxygen have classified as severe COVID with severe pneumonia, or they may have sepsis also. The other is non-severe COVID, and it's defined as absence of any criteria for severe or critical COVID. So these patients, mainly, they don't require oxygen. So the main difference is requirement of oxygen or not. The other is risk factor for deterioration. At the beginning, the risk factor for deterioration was taken from previous viral pneumonias, including H1N1. But we were not sure whether these risk factors were also working for COVID or not. But early report also showed age affects, or age is a risk factor for deterioration to severity. Comorbidities like diabetes, hypertension, obesity are also a severity for deterioration to severity, and smoking, and those patients having COPD and respiratory illnesses. The other is, are antimicrobials. These antimicrobials are working or not. From the beginning, we were having a lot of questions whether remdesivir is working or not, tocilizumab is working or not. And recently, like genokinase inhibitors, monoclonal antibodies, vitamins and minerals, progesterone, dexamethasone. So human beings are we're trying lots of medication available in the world, especially those medications who were used for other illnesses. Are they working for COVID or not? Was a question in the world. We will see some evidences. The first one was remdesivir. You remember remdesivir was told to treat COVID. It is an antiviral, and some of the top leaders also were saying it was a game changer. But lately we learned that remdesivir is not working. So there are lots of trials. So there are lots of trials coming out with the question of remdesivir, whether remdesivir is working or not. So the notable commonly mentioned trials were the ACT trial and the Spinner trial, Solidarity trial, where all over the world it was implemented all over the world, including in Ethiopia. We were part of the Solidarity trial and the WANG trial. So the number of patients involved were more than 1,000 in ACT trial and more than 5,000 in PARN trial. So in these trials, mostly severe and some non-severe illness were involved. Commonly, severe and critically sick patients were involved with the outcome of whether remdesivir decreases mortality or not, or time to clinical improvement. Most of the outcome was the same, like mortality and clinical improvement. So the dose being used was 100 milligram daily for 10 days for ACT trial. And we were involved in solidarity trial where 200 milligram was given in the first day and 100 milligram was given 10 days, where now we are practicing this remdesivir regimen for a treatment of COVID patients. So these are the publication regarding remdesivir, both in Lancet and in New England Journal. So most of it doesn't show clinical improvement, especially in critically sick patients. So in the first trial, there is a shortage of hospital stay, and in the second trial, there is no difference in clinical improvement and clinical status compared to standard care. And the others also didn't show significant improvement. Mostly they are showing shortage of in hospital stay or recovery time. The other drug which is being used in Ethiopia also, which is much expensive, is tocilizumab. It is requiring probably around 100,000. Remdesivir is not requiring more than 3,000 per dose. I'm not sure, but around that. Tocilizumab, I'm mentioning per dose per bir. Tocilizumab is previously used as arthritis. We know this drug, and it is interleukin-6 inhibitor. It is a recombinant monoclonal antibody. 2 trials showed improvement of patients using tocilizumab. One is a REMAP trial, and the recovery trial also showed improvement. So the first trial was in South Africa. This is a symptomatic review from South Africa. They reported at the beginning there was no difference in the mortality, in 28 mortality for those patients who are using tocilizumab and standard medication. But REMAP trial and the solidarity trial came, and both remdesivir and corticosteroid dexamethasone was given to patients, and it showed decrease in mortality and in hospital mortality, and the time to hospital discharge also has improved for those patients using tocilizumab and corticosteroid. The other trial was a recovery trial, which used tocilizumab and dexamethasone. And because we don't have tocilizumab, we were using also for those patients who have increased C-reactive protein. We were using increased amount of double dose of dexamethasone and prolonging the use of administration of dexamethasone. So the recovery trial showed improvement in 28 days mortality, time to discharge, and it showed mainly for those patients who are using both tocilizumab and dexamethasone. So you can imagine tocilizumab is immunosuppressive drug, and dexamethasone is also immunosuppressive. So there is high risk of infection and sepsis. So that is why the contraindications are common a lot, like those patients having significant immunosuppression, increased liver function test. That means those patients with sepsis, high risk of gastrointestinal perforation, serious sepsis, and WBC and platelet count lower. So those patients who have sepsis are contraindication for tocilizumab use, which most common patients being admitted in Ethiopia are having sepsis, so unable to give tocilizumab. The other group of drug is genuine kinase inhibitors, which are baricitinib and the other drugs, which is baricitinib is originally used for rheumatoid arthritis. We know this drug. So mainly they were trying this drug for sick patients, and it reduced mortality and reduced hospital length of stay. That is why in the current recommendation from WHO and other centers, they recommend a use of this drug for severe ill patients, not critically ill patients and those ambulating patients. So, and the other group of the other drugs which are genuine kinase inhibitors are not evidenced for COVID-19 treatment, like I don't know, ruxolitinib and tofacitinib. So these drugs have no improvement in COVID-19 mortality and hospital discharge. The other are monoclonal antibodies. Previously, it has been said there is no benefit of this drug, but currently, governments are buying for their community for ambulatory patients. So there are a lot of evidences which are being used for ambulatory patient or mild to moderate COVID-19 patients. They have improvement in COVID-19. Mostly, they are preventing hospitalization and progression to critically ill illness. So treatment is recommended for with these monoclonal antibodies, especially with the combination for with patients who have mild to moderate illness, and we have to treat them as soon as possible and within 10 days of symptom. And patients symptomatic and but not require oxygen, and those patients who are age greater than 12. So in most diseases, in most medications, the pediatrics and pregnant mothers are not involved. So it is difficult to recommend for this group of patients. The other drug, whether it is not working or not, was progesterone. So the question was, the mortality was higher in male patients and it is lower in reproductive age female patients. So what is present in reproductive age female patients and which is not present in adult male patient was people who were taking progesterone. So they tried 100 milligrams of subcutaneous progesterone for 5 days, whether it is working or not. So there is only one trial which involved 42 patients, 22 control and 20 progesterone group. So there is a better improvement in 7 days and other parameters and lower mechanical ventilation for those patients who were using progesterone. So progesterone is the same as dexamethasone. So, but it's only one trial, and it is difficult to recommend progesterone for the use of COVID-19 patients. The other question was aspirin. So aspirin, all aspirin trials research were just observational. So it inhibits viral replication, anticoagulation effect, anti-inflammatory effect. So as you know, it is a COX-2 inhibitor. So there is no randomized control trial for use of aspirin, but for just observational study, those patients who were taking aspirin have lesser mortality, both 30 days and 60 days mortality than those patients who were not taking aspirin. Aspirin was not given as a trial, but these patients were taking aspirin for other purposes like MI, stroke, and also another trial also involved lots of patients, and it is also just observational study, and there is mortality reduction for those patients who were using aspirin, but still difficult to recommend because these are just observational studies. And the other questions were whether vitamins, vitamin C, vitamin D, zinc, thiamines are working or not for COVID-19. People were just observing because most of the patients who were dying was old age patients, patients with comorbidity like hypertension, diabetes. So whether COVID-19 vitamin D is working or not for this kind of patients. So they were administering vitamin D. But the evidence was also not strong. Vitamin C and thiamine are being used for sepsis. As you know, sepsis is inappropriate host immune response and causing organ damage. So people were using vitamin C and vitamin D as part of sepsis management, but still there is no strong evidence to use vitamin C, thiamine, and zinc for a treatment of COVID. But as compassionate care, people are, including us, still giving vitamins, and sometimes, especially for pediatrics, you are giving zinc as a treatment of COVID, but still there is no strong evidence to use vitamins. So seeing this, how to manage COVID-19 patients as outpatients, non-admitted patients. So the most important part is supportive care. We will see what are those things. The other is reducing risk for COVID transmission in a household and other places. So the other is advising patients to come to health institution or follow up through telemedicine, remote monitoring, probably in-person visit and home visit by the nurse. So there should be a follow-up. So as you know, COVID is a happy hypoxic kind of situation. Like patients will not have respiratory distress, may not have tachypnea, but they will be desaturating. So better to have oxygen saturation pulse oximetry at home, and it is good to advise them and have a follow-up and health education for them when to return to hospital. So we can give them antipyretic, analgesics, and antitussive, and we can advise them prone positioning for those patients who are having pneumonia and some chest X-ray finding, but being managed as outpatient, and fluid administration, or they have to drink fluid to avoid dehydration because they may have complication, and rest during acute phase, and ambulation during. The other strong recommendation, especially in Western part, is monoclonal antibodies. So they are practicing this, like especially the combinations. So there is evidence to use these drugs, monoclonal antibody, as outpatient, not as inpatient. So our problem is commonly inpatient management. So I don't think we have this medication in our country, and it is not commonly, it's not a problem. So we are not prescribing. Dexamethasone has no evidence for outpatient management. Some countries are giving remdesivir as ambulatory management, but it's not approved by WHO and developing nation. We don't need anticoagulation for ambulatory patients, and we don't need baricitinib for ambulatory patients. Management of severe illness. So if the patient progresses to severe illnesses, that means the patient is having a dysregulated immune response. That is why septic patients are developing organ failure. And in addition to that, there is replication of SARS-CoV-2. So addressing these two things may be important for severe illnesses. So addressing host immune response, dexamethasone has a significant improvement. You know, the trial from UK, which were using 10 milligram of dexamethasone for 10 days daily, 60 milligram of dexamethasone, sorry, for 10 days. Now they are recommending even doubling of dexamethasone or prolonging of dexamethasone until hospital is there if the patient is having severe illness or high level of C-reactive protein. The other less recommendation is adding remdesivir, but it is not significantly recommended, but adding tocilizumab or baricitinib for patients who are having severe illness but not using a mechanical ventilator, there is significant mortality reduction. So these patients can be used, but it's difficult for us to get rapidly increasing oxygen need for these patients. So like evaluating patients, seeing these patients when they're requiring oxygen and prescribing tocilizumab. So these patients availing or getting tocilizumab is so difficult in Ethiopia, so we are giving dexamethasone. The other is critically sick patients. So the treatment evidenced for critically sick patients is dexamethasone plus tocilizumab. But to give tocilizumab, we have to consider those contraindications, and it should be within 24 hours of ICU admission, which is less likely to give it in Ethiopia. Either the patient will have contraindication, or it's difficult to get those patients within 24 hours. So it's less practiced in Ethiopia. The tocilizumab is recommended for critically sick patients. The other care for critically sick patients is infection control. We have to use like aerosol. It is aerosol aerosolizing situation. So N95 to be used. Airborne procedure should be decreased, and endotracheal intubation should be by experienced person, and video laryngoscopy better be used. As hemodynamic management in critically sick patients, as previously, crystalloids are recommended. Norepinephrine is a drug of choice for vasopressor, no difference. MAP target is around 65, it's also no difference. To decrease the norepinephrine amount, or to augment norepinephrine for those patients who are not responding for norepinephrine, we can use vasopressin or epinephrine in addition to norepinephrine. So the other is low-dose corticosteroid like hydrocortisone can be used for refractory shock and monitoring. So dynamic parameters are better used than static parameters. This is the monitoring part. The other is oxygenation and ventilation. Currently, high flow oxygen cannulas are more recommended than previous. As you know, we have a smaller machine for high flow nasal cannula. It doesn't mean making high oxygen amount in low flow cannulas like nasal prong, face mask, or reservoir mask. It is a different cannula, and that cannula can be connected to currently we are having a conventional mechanical ventilator who are supporting high flow nasal cannula, and we have a smaller machine, high flow nasal cannulas, which delivers up to 60 liters per minute of air with FiO2 as unit, and temperature up to 37 degrees centigrade, and it can deliver humidified air, comfortable to patients and air days. So it's evidence for air days, so better to use high flow nasal cannulas. And you can use non-invasive ventilation, but it is so difficult because there is patient comfort. And if the patient vomits, and there are also contraindications, so closely monitoring when the patient is using NIV is very important. And the other thing we forget or we not usually practicing is prone positioning. So for those patients who require oxygen higher than 60, better to prone them. That it requires human resource, skill and all, but still proning is recommended. And low tidal volume, as you know, in mechanical ventilator. So ventilator training, it requires 1 or 2 days, but just updating you how to ventilate a COVID-19 patient. So better to use low tidal volume, how to decrease low tidal volume regarding following their pH is also important. Targeting plateau pressure less than 30 is very important. It will create barotrauma. The other is volume trauma. The fluid management should be conservative. We don't have to give fluid and neuromuscular blocking, using it at up to 48 hours for those patients who are hypoxic. The other is ECMO. In previous viral illnesses like H1N1, ECMO was standard management, especially in Europe. Even if you don't have ECMO, but there is no evidence for COVID-19 patients for mortality benefit in ECMO. So it is not recommended to use ECMO. But people, other countries are using ECMO, but mortality benefit is less. At the beginning, all patients who were put on ECMO were dying. Recently, we have to check it. The other is anticoagulation. At the beginning, we were using therapeutic doses of heparin for those patients who are critically sick, because we couldn't rule out pulmonary embolism, and COVID, as you know, it is a hypercoagulable state. So we were using therapeutic dose of heparin for critically sick patients, but evidence is the reverse. We have to use therapeutic doses of heparin for those patients who are not critically sick. For critically sick patients, we have to use prophylactic doses of heparin. For critical ones, or for those patients for non-critical ones, and for those patients who are having higher D-dimer level, we have to use therapeutic dose of heparin for 14 days or until hospital discharge. But this is if we can rule out DVT or pulmonary embolism. Otherwise, the protocol goes to DVT or pulmonary embolism management. But for those milder patients and admitted to hospital. For outpatient management, we don't have to use heparin or enoxaheparin. For pregnant ladies, we have to use prophylactic doses of anticoagulant. For ambulatory and those patients being managed as outpatient, no need of anticoagulation. The other commonly asked question is management of concomitant infection, whether there is a difference in patients with tuberculosis, HIV management, and bacterial superinfection. Regarding tuberculosis and HIV or malaria management, we can use our local guideline. But for bacterial pneumonia, we are using antibiotic, but still the evidence is less. Only 9% of patients who are critically sick have confirmed bacterial superinfection, but we are using antibiotic because culture and sensitivity become less, and our yield is also less. So we are using antibiotic for those patients who are admitted to hospital. For those who are having severe pneumonia, ceftriaxone and azithromycin. For those patients who are developing hospital-acquired pneumonia, immunocompromised patient, critically sick patient, we are using or recommending ceftazidime and vancomycin. This is Ethiopian guideline, but most countries are not recommending antibiotic use unless the patient have strong evidence of bacterial superinfection. If the patient is not responding for ceftazidime vancomycin, still our country's protocol is recommending meropenem and vancomycin. In other places, as I told you, it is not recommended to use empiric antibiotic unless we have strong evidence of bacterial superinfection. And for milder and moderate illness, and for those ambulatory patients, it is not recommended to use antibiotic. The other commonly forgotten management of COVID-19 is rehabilitation. Patients who are critically sick will have lots of reason to have muscle weakness, bed sore, incontinence, and delirium and all. And currently, people are reporting severe fatigue, muscle ache, joint pain, including with Omicron variant. So rehabilitation, we don't have to forget for those critically sick patients, and improving or recovering COVID-19 patients. So it is not exhaustive to present rehabilitation here. Please refer WHO management guide and online course for how to rehabilitate COVID-19 patients after recovery. Commonly, they will have physical deconditioning and muscle weakness because of polyneuropathies. As you know, critical illness neuromyopathy is very common in critically ill septic or ARDS patients. It can be from hyperglycemia, it can be because of drugs. So inflammatory storm and muscle, drugs, neuromuscular, and steroids, metabolic changes like hyperglycemia, malnutrition, immobilization, and atrophy. They have a lot of reason to have muscle weakness. So after discharge, they will be having difficulty in functioning day-to-day activity. So physiotherapy and rehabilitation is very important. The other is lung function, impairment of lung function. After recovery and becoming negative in COVID-19, patient may require oxygen for a long time. We are having patients who have hypoxia for a long time after being negative. So they need lung rehabilitation. In some places also they are practicing lung transplantation after COVID-19. But in our center, at least we have to communicate with experts putting them on lung physiotherapy is very important. So the reason for lung function impairment after COVID recovery is like they will have repeated pneumonia, ARDS, pulmonary fibrosis is common after COVID-19. They may require prolonged oxygen and pulmonary embolism and damage to respiratory muscle, immobility and atrophy. This all can cause lung function impairment. So it needs rehabilitation. So physiotherapy of the lung. At last, they may have cognitive and mental impairment. This can be because of viral invasion and involvement in the brain. When you do LP, you can find viruses, the COVID viruses in the CSF. So they may have meningitis, encephalitis, they may have stroke-like symptoms. So they need rehabilitation, physiotherapy. An advanced effect of hypoxia can cause, adverse effect of hypoxia can cause cognitive impairment. So they need rehabilitation. So the other can trauma post-COVID, post-ICU can cause trauma-like experience, and they may have anxiety and mental impairment. So this is not exhaustive. Rehabilitation is not exhaustive. That just I want to trigger you to read the importance of post-COVID-19 rehabilitation. I think these are my presentation. I hope you have got something from this presentation, and we will leave the rest of the time for question and answer. Thank you very much.
Okay, thank you so much, Dr. Menbeu. So we have a very limited time. So we will have a limited number of questions. So anybody who wants to ask a question, you can raise your hands
In the meantime, there is one question in the chat box which says the use of dexamethasone in the fungal infection. So this is very important issue. I think Dr. Filimona. So in our experience, we follow the risks for fungal superinfection. Fungal infection is common in COVID-19 patients as compared to the other patients because we are using commonly immunosuppressive drugs like dexamethasone, and these patients will have immunosuppression, critical illness, multiple tubes. So we add antifungal for those patients who are febrile and not responding for our strong antibiotic after 4 days of admission. So considering antifungal for COVID-19 critically sick patient, especially for intubated critically sick patient and not responding for our antibiotic after 4 days of admission, we consider antifungals, and as the same as other critically sick patients, high suspicion for fungal superinfection is very important.
Thank you. It was a nice presentation. And regarding the immunosuppressive cases, especially patients in our country, RVA patients with low CD4 count, like less than 100 or less than 50, and what is your recommendation with dexamethasone or steroid at all, and their CD4 counts regarding?
Okay, I think it is very important question. Thank you. But the report for HIV on the role of HIV on COVID-19 is conflicting. The report from South Africa, it says when COVID-19 RVI patients, especially those who have low CD4 count and having RVI COVID superinfection, the mortality was higher. In European countries, they were saying the mortality of patients who are having HIV and COVID-19 was lower. Their explanation was mostly the COVID-19 patients will have critical illness because of inappropriate host immune response. So RVI patients will not mount inappropriate host immune response. So they were saying they will improve, they have less severity. But in South Africa, they are saying the mortality is high. In our center, if we are ask our experience, we were reviewing the number of the days in our centers. So there are patients who are RVI positive and died, commonly dying in our center, but they were dying mostly from the opportunistic infections of RVI. So still, we are not sure. And the other explanation from Western setting was ART drug was helping them to reduce the mortality and viral load. So we are not sure the impact of RVI on COVID-19 still, because there are conflicting reports. But in our center, we can see either they are discontinuing their medication, or they are acquiring COVID-19 in the hospital because they are coming frequently to hospital, and on top of their critical illness of RVI, on top of RVI, having COVID-19 may cause increased mortality, but it needs more research and study. So it is conflicting report. So, so the other question I can see is from chat box. I think high flow nasal cannula and CPAP. So CPAP class 1A evidence for CPAP is pulmonary edema and COPD patients. High flow nasal cannulas are mainly used for hypoxic patients. For those patients in pre-oxygenation for intubation, it has more comfort for hypoxic patients. And CPAP has less evidence for ARDS and hypoxic patients, and more comfort in high flow nasal cannula. So high flow nasal cannula is more recommended in patients with ARDS. So than CPAP. So CPAP is mainly for COPD, but in our center we are using CPAP because our experience in high flow nasal cannula is less, and it is less prevalent. We don't have high flow nasal cannula common in our common centers, and our experience is less, but better to try high flow nasal cannula. The other is, does Omicron has more GI symptoms than the other variant? I think the percentage, I have to check the percentage of Omicron reports. There was in the first report was for 71 patients and 150 patients. The GI symptom was not significant. Mainly upper respiratory symptom was significant. But in old age, a typical presentation including GI symptom is common. But overall GI symptom, I think we have to check. In the first two reports, I didn't see increment in GI report. The other is RDT versus PCR for testing COVID-19, pros and cons. There is a good algorithm from WHO regarding RDT and PCR. So RDT is not recommended for confirmatory tests and in less prevalent time. So RDT, like you remember in the, 2 weeks ago, or 3 weeks ago, we are having high number of COVID. So in that time, we can use as a screening tool, RDT, but we can't use as a confirmatory test. PCR, we can use it as a confirmatory test. So currently the case is decreasing. We have to focus it to PCR. So RDT is as a screening tool. The other, even though it is not on the recommendation, can we use aspirin for management? It is not recommended to use aspirin. From our experience, we were using aspirin at the beginning, but the bleeding has increased. When you use heparin and aspirin, because heparin is recommended. When you add heparin on top of aspirin on top of heparin, the bleeding risk is high. Upper GI bleeding and other site bleeding is high. So still, because it's not recommended, better to avoid using aspirin unless the patient have clear indication like MI, stroke, and other indication for aspirin. So the other question which I see from chat box. So Dr. Santayo, COVID-19 week back and stayed for last 10 days, but at discharge he was desaturation of oxygen. Any reason? So we were discussing this. So in lots of African nations, ICUs are being occupied by post-COVID patients, including ours, because post-COVID-19 ARDS, patients will develop lung fibrosis, atelectasis, lots of complications, and patients will continue being hypoxic and desaturating. We have to put them on oxygen. They will have increment in risk of pneumonia, but they need respiratory physiotherapy and rehabilitation. How to do respiratory rehabilitation and physiotherapy? Please refer to WHO guidelines. It has a very good online course on rehabilitation. So Dr. Sentayo, because the time is very short, please refer to WHO online course for rehabilitation of patients who have hypoxia after COVID-19. Your patient is hypoxic, but most patients, there are patients who requires ICU, continuity of ICU mechanical ventilator, even after recovery. So that is why now in some places they are also practicing lung transplant. So I recommend you how to do lung physiotherapy and rehabilitation for this kind of patient, but the reasons are in my presentation. You can get it. What is your experience with COVID encephalopathy and all the patients? So as you know, this is from Hayat. So commonly in all the patients, they will have sepsis. Sepsis is typically inappropriate host immune response. It is not common to have early encephalopathy in COVID-19 patients as like other sepsis, bacterial sepsis patients. But in COVID, they will have CNS involvement, stroke-like symptom, encephalopathies, but encephalopathy is less common in COVID-19 patients as compared to other septic patients. But ARDS, renal failure are common in COVID-19 septic patients. Encephalopathy is less common, and it recovers. That is why people say happy hypoxia. Patients will be conscious but hypoxic. The other is a place of decongestant and cough suppressants in mild COVID. So this is recommended, cough suppressant and decongestants, because it's symptomatic treatment in milder patients. We have to give them. Okay, Dr. Sentayo, sorry for naming you differently. The other is from Doug Mfisa. We were changing the dose of, I don't know what UFH mean? Oh, it is unfractionated heparin. Whenever the patient worsens despite solid evidence of PE or lab result for D-dimer. If we have high suspicion for PE, we can use clinical scoring, or if you have clinically a high suspicion of PE, you can give them therapeutic dose of PE. Otherwise, if you can rule out pulmonary embolism in critically sick COVID-19 patient, the recommendation is prophylactic dose of prophylactic dose of heparin, either enoxaheparin or so. Still, it is so difficult to take them for CT scan, and ultrasound is also difficult in most places. Still, we are practicing therapeutic dose of heparin, but the recommendation is prophylactic dose of heparin. D-dimer is so difficult to get it, and because the patient is septic, they will have high level of D-dimer. So for those patients, we have to give them a therapeutic dose of heparin. So the other is, why is this increased case of myocarditis and acute renal failure in case of Omicron variant? Honestly, whether it has increased or not, myocarditis or acute renal failure, I'm not sure. Myocarditis is more common in pediatric cases. Pediatric viral pneumonia can cause myocarditis. It is not only in Omicron cases. Previously in Delta and Alpha variants, also they were having myocarditis. Whether it is increasing in Omicron or not, especially in adult patients, I have no reading. We have to check that. But in my experience, we didn't see increment in myocarditis. Acute renal failure, maybe. And the reason, I'm not sure. In general, the Omicron variant has lesser hypersensitivity response or inappropriate host-immune response. So they would have less acute renal failure. So COVID and asthma, any recommendation? There is no difference, COVID and asthma recommendation, but better to less use bronchodilators. So in COVID, especially in clear COVID patients, they don't recommend using bronchodilators. Otherwise, there is no difference. Thanks for update. So the other one last question is tocilizumab and hypersensitivity reaction. And it is asking my experience. Honestly speaking, this is from Abraham. We are not comfortable in using tocilizumab, especially in Ethiopia, because the cold chain, it needs refrigeration. It's being expensive. We are getting tocilizumab lately when the patient is getting sepsis, and mostly patients having contraindication. Whether it is hypersensitivity or not, all patients who took tocilizumab has deteriorated. If you ask my experience, whether it is reaction or not, I'm not sure. I don't think it was reaction. Only one patient may have reaction, but tocilizumab in our center, it is not a kind of drug to advocate or to recommend, because it comes with in black market. We don't know how people are bringing it, and sometimes we are not sure whether it was tocilizumab or not, because people are paying hundreds of thousands for it, and when you give them, it's already late. So patients will develop a kind of hypersensitivity, but I don't think it's more of a flare of sepsis and superinfection, and the patient will have a deteriorative course and dying. Thank you very much. So at last, I say thank you very much for all your attention. This is just in my short reading, just to sensitize you to read more on COVID, because COVID will stay with us for, I don't know for how long, but because most community is not vaccinated, I'm thinking it will increase, or it will continue being with us. So thank you very much. So whatever I told you or in my presentation may change tomorrow, and lots of things are missing. Please continue reading. Thank you very much. Back to the host.
Okay. Thank you so much, Doctor, for updating us. And you took really long time for the question and answer, and that is really good. I think most of the questions are answered. I'm really sorry, guys, for not letting you ask your question, because this is because we have a really limited time. I have already posted a quiz, which is on Google Form. Guy, you can answer those questions, and participants it's actually 4 questions, and participants who get more than or equal to 75% result will be getting 1 CEU CPD certificate from Blue Health Ethiopia, and we will be emailing you that certificate as soon as we are finished with the certificate. At last, I would really like to thank you all for participating in this webinar. I know there are a lot of people who didn't join here, and we will try to upgrade our Zoom service so it can hold more than 100 participants. I really like to apologize for those who are not, who did not join us here. And this session is currently recorded, and we'll be posting this session on our YouTube, and also we'll promote that link on our social media. So please follow us on all our social medias, and you'll get updates on every seminars. Okay, at last, I would really like to thank Dr. Menbeu for joining us at this time and giving us this update. And I would like to say thank you all, and have a really great night.